So the Violet study, I'll say importantly, was named after John Violet, who unfortunately passed away. But it's the first study that is targeting PSMA with actually the same ligand as people used before, PSMA-INT, but has a Terbium-161 conjugated to it, so which has both beta as well as Auger emission. I think most people are familiar with beta, but Auger is a high energy but very short range, shorter than even alpha molecule. So it was the dose escalation study. They went up to 7.4 gigabecquerel, did not have DLTs, but that was the end. That was what was the initially planned study. Patient selection very much akin to therapy. So it had to have at least one very high SUV. The others couldn't be too low, and also no discordance in terms of FDG positive but PSMA negative. And in that patient population, had a pretty good PSA decline, so about a 70% PSA 50, and I think it was about a 40% PSA 90. Durability is hard to judge in a non-randomized trial, but I thought it looked very impressive for a phase 1 small study. The plan is to escalate the dose, at least the injected amount of reactivity, and expand that. And additional biomarkers are in progress. That includes patient-reported outcomes, but also more in depth in terms of imaging. What is unknown is that all the beta part of the terbium, or is there any contribution from the Auger? The Auger should be, if there's any micrometastatic disease, which I think is likely to be existence in almost every patient, that would be, more likely to work in that setting. But of course we can't see it, and PSMA INT as well as 617 does not always stay internalized, which doesn't really matter for a beta or even an alpha, but for an Auger, the range is so short, it really needs to be near the nucleus. So I'd say overall the therapy looks very promising. Unclear the contribution of the beta versus the Auger.